Okay, let's start with a number. $2 to $4 million.
Right.
Now, when you hear that in a hospital setting, you're probably thinking, what, a new wing?
A new wing, maybe a whole fleet of new MRI machines, something
Mm,
big.
exactly. Some massive capital project. But for this deep dive, we're looking at a proposal that claims it can get there with, well, just one person, a single role.
It sounds like an exaggeration, honestly.
Yeah.
But when you really get into the mechanics of hospital finance,
Mm.
especially the gap between clinical care and getting paid for it, the math is, well, it's surprisingly solid.
And that's what we're digging into. We've got a proposal script here. It's called the Stat Nurse Clinical Revenue Protection System. It's written by a man named Timothy Simpson.
Yeah, he's a CCRN, a critical care nurse with something like 22 years of ICU experience.
But this document, it doesn't read like a clinical paper. It's more like a pitch deck. He's making a business case, arguing that the most expensive leaks in a hospital aren't, supplies or inefficiencies.
No, he's saying they're failures of clinical judgment right at the bedside.
It's a bold claim. Usually, revenue protection means billing coders or negotiating with suppliers. Simpson's flipping that entirely.
He is. He's saying that a patient going into septic shock isn't just a medical tragedy. In his words, it's a revenue protection failure. He's stripping out the emotion to show the C-suite the cold, hard price tag.
Let's talk about that price tag. He calls it financial hemorrhage, and he gets very specific about the costs.
And that's what makes it so compelling. Take sepsis. We all know the clinical protocols, the so-called bundles.
Right, the steps you have to follow.
But Simpson focuses on what he calls a bundle failure. So you miss one of those steps. Maybe the antibiotics are an hour late or a lab isn't rechecked on time. That's not just a clinical misstep.
It triggers a huge financial penalty, he says. $15,000 to $40,000. Per failure, that seems really high.
It is, but it's a realized loss. It all comes down to the DRG, the diagnosis-related group. If you miss the quality metrics, CMS and other payers can basically penalize your reimbursement.
So you're spending more to treat a sicker patient.
Exactly. You're spending maybe $60,000 treating them in the ICU, but you're only getting paid $20,000 because you missed that window. You're completely underwater on that patient.
Wow. Okay, so that's sepsis. What about his other points? He mentions ICU boarding.
Yeah, this is a huge one. An ICU patient is stable enough to leave, but there are no beds on the regular floor, so they just sit there.
And he puts a number on that, too. $3,000 to $5,000 a day in suppressed revenue.
That's the opportunity cost. That bed is being occupied by a stable patient, so you can't bring in a new high-revenue post-op surgical patient. You are literally turning away business because your patient flow is jammed.
And on top of that, you have readmissions, which brings CMS penalties, and then nurse turnover. I thought those numbers were stark. $40,000 to $65,000 to replace one experienced nurse.
And I would argue that's low. Factor in hiring agency nurses to cover the gap, training the new person. It's probably closer to six figures. But his whole point is that hospitals they eat these costs.
They treat it as the cost of doing business.
Exactly. It's reactive. The bad thing happens, you pay the bill. The entire idea of this stat nurse is to shift from absorbing the hit to intercepting it.
Okay, let's define the role then, because my first thought is, don't we already have people for this? Charge nurses, rapid response teams, case managers.
That's the $4 million question, isn't it? The problem is a charge nurse is buried in operations, staffing, logistics, family complaints.
They don't have time to just watch monitors.
And the rapid response team, they're firefighters. They show up after the alarm has been pulled. They're, by definition, reactive.
So where does the stat nurse fit?
In the gap. Simpson calls this role a high judgment interceptor. They don't have a patient assignment. They're not doing paperwork for discharges. They're covering 200 to 300 beds.
How is that even possible? One person for 300 beds? They can't see every patient.
They don't have to. This is where the systems thinking comes in. They use what he calls trigger-based surveillance. They aren't going room to room. They're watching real-time data for the entire hospital, looking for the outliers.
Can you give me an example? What does that look like on a normal day?
Sure. Imagine a busy floor. The bedside nurse has 5 other patients. In room 304, a patient's heart rate has slowly crept up from 80 to 110 over a few hours. Blood pressure's a little soft, maybe 95 over 60.
Nothing that would trigger a critical alarm, not yet.
Right. But the stat nurse watching a dashboard sees that trend. They see a lab value that's technically normal but trending up. They put it all together and think, this looks like early sepsis.
And they just walk down to the floor.
They walk to the unit, find the nurse, and say, hey, I'm seeing some soft signs in 304. Let's get a fluid bolus going now.
Oh.
They intervene before the patient actually crashes.
So they prevent the ICU transfer. They prevent the bundle failure.
Exactly. And that single action, that interception, just saved the hospital tens of thousands of dollars.
Okay, I was play devil's advocate. You drop this expert onto a unit to essentially tell other experienced nurses what to do. Doesn't that create turf wars? Resentment.
It's a huge risk, a huge one. And Simpson addresses it by how you frame the role. They're not a supervisor. They're not management. He calls them air traffic control.
I'm here to watch your back?
Precisely. It has to feel like mentorship, not policing. If you get the culture wrong, the whole system collapses.
All right, let's get into the strategy he lays out. He calls it the 5 forms of leverage. This is the core of his pitch, really. It's code, media, capital, labor, and products.
And this is where it gets really interesting, because this isn't medicine. It's pure business strategy applied to a clinical environment.
Let's start with code. We kind of touched on it, the automated surveillance.
Right. This is the force multiplier. A human can't watch 300 charts, but an algorithm can. The electronic health record flags patients, sepsis risk in 402, deterioration risk in 108, and pings the stat nurse.
Okay, next is media, executive visibility. This one felt a little cynical to me.
I see why, but it's about political reality inside a hospital. Prevention is invisible. If you stop a patient from having a stroke, there's no drama, no fire to put out. So you have to visualize the save.
So you put a dashboard in the CEO's office that says, margin protected today, $15,000.
You got it. It reframes nursing from a cost center to a profit protector. If you don't do the media part, a new CFO comes in a year later, looks at the budget, and cuts the extra nurse because they don't see the value.
Which leads right into capital, the ROI.
And he's aggressive here. He's talking a 3 to 5 times return on investment in the first year alone.
That's a wild claim for any new hospital initiative. How does he justify it?
By focusing on that low-hanging fruit, sepsis and patient flow. The math is simple. If you prevent just 10 or 15 of those big sepsis reimbursement failures in a whole year,
you've paid for the nurse's salary.
you've paid for the salary.
Yeah.
Everything after that is pure profit for the hospital.
Then there's labor, strategic deployment.
Yeah, instead of spending millions to hire 10 more floor nurses to lower your patient ratios, you hire one strategic nurse to support the existing staff. It's a much more efficient way to add a layer of safety.
And the last one is product CTS, intellectual property. This one hints that he's thinking bigger than just one job.
This is the scaling mechanism. Once you create the playbook, the protocols, the algorithms, the mentorship curriculum, that becomes a company asset. You can copy and paste that system to every other hospital in your network for basically zero marginal cost.
It's a franchise model.
It's a franchise model for clinical risk management.
I want to go back to the operational side. He lists 8 domains. We've talked a lot about sepsis, but nurse mentorship stood out. That seems like a soft skill he's trying to put a dollar value on.
It's a soft skill with a very hard dollar value. You have new graduate nurses hitting the floor, they're overwhelmed, they burn out, and they quit within a year.
Right.
Having that stat nurse, that veteran, who can come by and say, hey, take a breath, let's walk through this together, is a powerful retention tool.
It's a safety net for the staff, not just the patients.
And if that safety net stops 2 or 3 nurses from leaving in a year, you just saved over $100,000 in recruitment costs. It's a real number.
Then there's documentation protection. Sounds boring, but I'm guessing it's huge for the financial side.
Oh, it's vital. A busy doctor might write, patient has infection. But for billing, the coder needs sepsis due to E. coli with acute organ dysfunction. The stat nurse can help ensure the chart accurately reflects the patient's severity in real time.
So the hospital gets paid what it's actually owed?
It's defensive accounting at the bedside.
So it's a strong pitch. But if I'm a hospital exec, I'm still nervous. It's a new salary, a new role. How does he get them to say yes?
With the 90-day pilot, it's a brilliant sales tactic, a psychological trap, in a good way. He doesn't ask for a new permanent department. He just asks for a 90-day trial.
Try before you buy.
Exactly. He says, let's track 5 specific metrics. Sepsis fallouts prevented, ICU hold hours reduced. We measure it for 90 days.
And the risk calculation is the real genius here.
Right. He basically says the risk of not trying this is greater than the risk of trying it. If it doesn't work, okay, you stop. You're out 3 months' salary, no big deal.
But if you say no from the start,
you're implicitly saying, I'm comfortable continuing to lose millions of dollars a year on these preventable problems It corners them.
Looking bigger picture, he even suggests this could evolve into a C-suite role, a chief clinical risk officer.
Yeah, this is the long-term vision. Right now, who owns this? Risk management is lawyers. Quality is compliance. Finance is accountants. There's no one at the executive table who truly understands how a subtle change in a patient's vital signs in room 304 will eventually hit the quarterly earnings report.
He's creating a new discipline.
He's trying to. He sees this role as the seed for an entire enterprise-level system, maybe even supported by AI down the road. It's about building an infrastructure of judgment.
He has that great quote, judgment compounds, accountability compounds.
That's it. A checklist is static. But human judgment, backed by good data, gets smarter and more valuable over time. The safety net just gets tighter and tighter.
So let's wrap this up. What's the big takeaway for someone listening who isn't running a hospital?
I think it's the simple idea of interception. In almost any complex field, not just healthcare, we spend so much time looking in the rearview mirror. We analyze last quarter's failures.
We study the crash site.
Yes,
Yeah.
we study the crash site. Simpson's whole model is a challenge to build systems that look at the radar before the crash. Whether you're in logistics or software or finance, are you set up to absorb risk or to intercept it?
And crucially, do you have someone with high judgment who is actually empowered to act on what they see?
That's the key, because detection without the authority to act is, well, it's worthless. You need the person who can see the smoke and pull the fire alarm.
A really fascinating way to think about how deep expertise can actually be the ultimate financial tool. That's all for this deep dive.
Stay curious.